Hello and welcome to the Public Policy Lab interview series. I'm Judith Levine, the director of the Public Policy Lab, an interdisciplinary research center in the College of Liberal Arts at Temple University. We are hosting a series of conversations with experts on the policy impact of the COVID-19 pandemic. I'm grateful to be joined today by Dr. Harold Pollack, who is the Helen Ross Professor of Social Service Administration at the University of Chicago, where he is also the co-director of the University of Chicago Health Lab and the University of Chicago Crime Lab. He earned his undergraduate degree from Princeton University, and his master's and doctoral degrees are in public policy from the Kennedy School of Government at Harvard University. Dr. Pollack is an economist specializing in health policy, but his work has spanned many fields, including poverty, crime, the opioid epidemic, and even retirement planning. Given that each of these areas is impacted by the COVID-19 crisis, Professor Pollack is a particularly suitable guest for us. Thank you for joining us, Harold.
It's so great to be with you, Judith, and to talk to you.
Well, thanks so much for joining us. So let's start with a very basic question that many find particularly confusing. How is it possible that the U.S. healthcare system is so well funded, particularly in certain areas like high-tech, cutting-edge technology, and yet we don't have enough masks and ventilators for this current crisis?
That's the $64,000 question. And the truth is that COVID-19 is exposing a very chronic failure of the American healthcare political economy that has gone on for decades. You know, we spend $3.6 trillion on medical services in the United States every year. That we spend way more per capita, way more as a proportion of our gross domestic product than any other wealthy democracy does. And yet, these basic public health tasks have always been left behind and neglected. The local health departments have been badly underfunded for over the past decade. The number of jobs in local health departments has declined. I find it just so frustrating. My wife is a medical social worker at Lurie Children's Hospital here in Chicago, which is a wonderful institution. And they have a fish tank at Lurie Children's Hospital that costs more than the buildings of many of the public health and social service agencies that I work with. And I think in part it's that personal clinical medical services have a very concentrated set of interests behind them. Their value is obvious, and it's just always been the case that we will spend many, many times more to develop advanced lung cancer treatments than we will to even staff the telephone line that you can call if you want to quit smoking. And it's such a failure. I hope that COVID-19 provides a wake-up call for us. Then again, I would have hoped that the HIV epidemic, the crack epidemic, lung cancer, many other things would have provided that wake-up call. So we'll see. But it is a national chronic failure that goes far deeper than the particular supply chain for ventilators or anything like that. One thing I like to say about public health is it's incredibly boring until it isn't. And right now we're in that it isn't period.
Right. You actually wrote an op-ed for the Washington Post recently that was entitled "The Silver Lining of the Market Crash, Making the Wealthy Worry More About Coronavirus." That seems to be really relevant. Your argument in that piece is really relevant for what you've just been saying. Can you talk a little bit more about what you meant by how this connects to the market crash?
Yeah, I must say that the market has crashed a lot further than it was crashing at the moment that I wrote that piece. So I think the universe was playing a little bit of a karmic joke on me after that came out. Well, I think that there's a sense of impunity among many people like myself, who are highly educated, have good jobs, have high incomes, about many of the most serious public health challenges that we have in the society. And there's a sense that these are things that affect those other people and they don't affect us. And I started my career with the HIV and crack epidemics. And everybody that I talked to was sad about those things, but there was not this immediate sense of urgency, the sense that we are one society, that we all are at risk. That was probably not the case in these earlier public health challenges. I think the opiate epidemic has been more inclusive in that way. But I think that it would be a fantastic thing if the next time there was some sort of a potential public health scare, if Jim Cramer on CNBC and people on financial cable TV were sitting there screaming about job vacancies at CDC and questions about public health preparedness the way that they do about what the Fed is doing, or things that people view as affecting financial markets. And it is when the stock market really goes down, it gets our attention in a very visceral way. I don't know about you, but I certainly, I know, I check my 401k, and that is, that's often a way to get people's attention, unfortunately, in the world in which we live.
Harold, you're a health policy expert. Don't you know that checking your 401k right now is bad for mental health?
Yeah, well, there's that Bruce Springsteen song, "You Can Look But Don't Touch." That's kind of my philosophy
of retirement
yes,
planning right now.
but you're absolutely correct. Yeah, we'll come back to that.
Yes. So okay, you've talked about we are not ready and we don't pay attention to public health infrastructure. So what changes do we need to make us better prepared for the next crisis that comes down the road?
Well, I think that after this COVID-19 crisis has at least passed its acute phase, I think we need to do several things. One is, I think we need a sort of 9/11 commission type retrospective that really looks carefully at both at the nitty-gritty granular questions about strategic stockpiles and so on, but also how the government has to be organized so that we are constantly on top of this. And it is striking that when the Obama team left, there was in the National Security Council a pandemic response unit. There are structures that we could put in place to ensure that we have the highest level of attention and vigilance applied to potential public health threats. And I don't think those structures are in place now. I also think that we just need to systematically allocate more resources to public health with a recognition that it's incredibly boring and seems like an incredible waste of money to take a couple 100 million masks and throw them in a stockpile when you may never need them, or to have ventilators sitting around. And I think we have to, as a society, realize that we need to be spending 2% more of our healthcare dollars permanently on public health preparedness. This is not going to be the last thing that we're going to face. Climate change is going to present profound challenges. Other pandemics are going to arise in our globalized world, and so we have to be constantly ready and make that. In the same way that we have an intelligence community that is constantly looking out for terrorist threats and spends a lot of money and develops significant resources all the time, that's what we need in public health. And we need to have the highest level of the federal and state governments constantly working on what would we do if we had a pandemic that came out where we had limited capacity to test. How do we respond? We had months of leeway. We didn't have a huge amount of leeway, but we had a couple of months of time where we could have been preparing. And you can't build government structures in a couple of months. Those are either in place or not. And President Trump has made a variety of specific management failures in this epidemic. But some of that is that their structures were not in place to do those things below the level of the president, because you can't count on vigilant and immediate presidential leadership to deal with an obscure threat, particularly one that may or may not materialize. That's just not the way that you deal with a systematic issue like this.
Can you say a little bit more about these kinds of structures or procedures that have not been in place that you're referring to?
Well, there were various efforts to war game out what would we do if there were a pandemic. That some of them right at the transition point between the Obama and Trump years, there were people specifically worried about this, and trying to run war games, basically to say, okay, how many ventilators would we have if we had a pandemic that spread out in this way, and then and presumably what you have to do is then take the results of those bureaucratic exercises and say, okay, now here's a set of government organizations that have billions of dollars that can then develop the capacities that were shown to be shown to be wanting in our best efforts of what something like this would look like. And so we just have not, when we do terrorism wargaming, we sometimes discover, hey, we need substantially more capacity in a particular area, and then the Pentagon makes a long-term investment, and some of those investments turn out to be needed. Fortunately, most of those investments turn out not to be needed, but they are there, and even if only 10% of them turn out to be useful, that is often an excellent investment given what's at stake. And that's the way that we need to think about this.
The current crisis is really highlighting how health problems are tied to other social problems, and that many of our systems maybe only treat one thing. So just for instance, homelessness. How do you test and treat people who are experiencing homelessness in the middle of this crisis? You need to be able to find people again in order to give them their test results. You need to have them be somewhere safe for themselves and others should they test positively. So can you talk a little bit about the interconnected nature of this, and then I'll ask you, what do we do about that? But if you could just lay out what the connections you see as being problematic.
So those connections, as you point out, severely vulnerable populations are where it's the most obvious, where we have street homeless people who are exposed to tremendous risk. Finding people, testing them, and then finding a place for them to be where they're physically safe and others are physically safe is a huge challenge. But it percolates through in so many other disparities in American society. Here in Cook County, something like 70% of the fatalities have occurred among African Americans, who are far less than 70% of the population. Maybe they're 25% of the population. And many of the people that have died are older people who have co-occurring physical vulnerabilities, whether it's asthma, obesity, other challenges that people have. And they're more exposed to COVID because of their social circumstances, and they're more physically vulnerable because of their health circumstances. And we don't have great systems to help. And we can provide excellent acute care for COVID if they show up at the University of Chicago Medical Center, but that's often, that's the last line of defense that you want to lean on. And so we have a lot of evidence that it is harder for people to be safe when they lack economic resources. So I'm sitting in my basement. I have a house, I have a basement office, I have nice Wi-Fi. I can do a ton of my work sitting at home, on email, on Zoom. I have a paycheck that's coming in. I don't have to go outside, to do my work. I'm under much less stress financially and otherwise than many people, and just hundreds of thousands of people within a couple of miles of where I'm sitting just lead fundamentally different lives from that. They have to be out to do their work. They don't have their kids. If their kids are home from public school, they're not well set up to participate in e-learning through their school. There's just so many ways that that the disparities are just jumping out at us. I mean, in New York City, the most recent statistics are that the Bronx has a three times as high a per capita fatality rate as Manhattan, and we know every disparity that's contributing to that, and so
and of course that has to do with both disparities in people's underlying health conditions and also in their access to medical care.
Absolutely.
Yeah.
And ironically, many of the people that are the most at risk are the people that are on the front lines doing the things that are the most important. The person who is on the cleaning janitorial staff, who's going through the big box store, cleaning the doorknobs and wiping off the surfaces so that all the shoppers can be safe. that person's often at much greater risk than the shoppers who are coming in once a week to buy their toilet paper and their popcorn. So this epidemic is a mirror to many inequalities in our society.
Right. Buy their toilet paper if they're lucky.
Yes. Yes. So at least walk over to the empty shelf. Yes.
So what kind of social programs do you see as key in battling these kinds of interrelated problems? Our social programming isn't set up for this kind of interrelated problem, but what programs do you see as most promising?
By far the most important program is Medicaid. Really, everything that we're going to do in public health or in dealing with the social determinants of health that are proximate to health outcomes, Medicaid is going to be the financial oxygen for whatever we do. It's a $500 billion program. It dwarfs everything else. And if you're talking about supportive housing or many other things, either we're going to finance it through Medicaid or it's probably not going to happen. By the way, this goes back to so many issues that I've worked on in my public health career, where Medicaid, you can get, say in the case of HIV, people can get excellent HIV care that Medicaid will pay for, throughout America. You want to send outreach workers out to find the people that are at highest risk of highest risk of HIV and highest risk of infecting other people. That's a public health activity, and Medicaid probably doesn't pay for that, and so it often doesn't happen. It's underfunded. And when we think about how do we deal with people who live with serious mental illness, who need a physical place to live, they need housing. Now, one of the sad things is that Medicaid actually often does that for specific populations. The argument for it is often a very straightforward cost-benefit analysis. Like, we can keep this person out of the emergency room if we give them a sheltered place to be. And that's often true or plausible, but there's an aspect of that argument that is just terrible. It's saying, here's this person who's living out in the street, and we're trying to argue, do we have an obligation to find that person a roof over his head where he can be safe? And the argument hinges on, well, is he going to annoy us by going to our emergency department? And can we make him annoy us less often if we put him in the supported housing? And that's so backwards. I think we need to reconceive Medicaid as a population health program and much more openly finance things that improve people's well-being.
Mm-hmm. What do you see as the likelihood of that coming out of this sort of change?
I think it's happening because I think governors see Medicaid as a key tool to solve problems for them. If we were doing a companion conversation about the Affordable Care Act, one of the ironies of the Affordable Care Act is that the ACA Medicaid expansion is the jewel of Obamacare and has tremendous support among Republican governors because it solves practical problems for them. And the more private market-oriented marketplaces in the Affordable Care Act, nobody owns those except Barack Obama, and he's not president anymore. And I think a lot of governors and a lot of elected office holders from both parties, they know homelessness is a big problem. They know all other social determinants are a big problem. And they're looking for, what do I have in the toolkit that can help pay for it? And by the way, if the federal government can pay the majority of what's being paid, that's even better. And so Medicaid ends up being a tool that often in a quiet way, but sometimes in a public way, people across the ideological spectrum are increasingly using to deal with addiction, to deal with homelessness, to deal with a lot of problems. And I'm actually very optimistic about the future of Medicaid in that way, because I think it's just a very useful, practical tool for the state and federal governments on all sorts of things.
Another area of your expertise is crime and the criminal justice system. Clearly, there's a huge public health problem with any kind of group quarters. Can you talk about what kind of risks current detainees are facing? And maybe in that discussion, you could also talk about whether we're seeing changes in crime rates of various kinds.
So let me start with the institutional sort of structures of criminal justice. The correctional setting is a petri dish. You have people who are physically on top of each other. You have staff who cannot maintain, if you say you have to stay 6 feet apart, you just can't always do that in the correctional environment. It's just really hard to do. You have, especially, I should distinguish jails and prisons. In a prison, you have a pretty stable population of people that are there for a while. And in a jail, what you have is this constant flow of people in and out, and constant flow of visitors, and constant flow of various kinds of service providers who are moving in and out of the building a lot. So like the Cook County Jail it's just a really free-flowing ecosystem that is very, very hard to keep fully safe. And we do studies every night in the jail that are now on hold in what's called the discharge lounge, which is sort of this area, this long hallway and physical space where people go through when they leave. And there's just a lot of people close to each other in those environments, and a lot of staff members that are there. And many of the people there are homeless, or are people who inject drugs, or people who have other kinds of risk factors that would put them at a heightened risk for COVID. And every jail in the United States is really, really working hard to try to say, how can we minimize the risk? Places, so we know at Rikers and we know at Cook County and other jails that there have been a significant number of known COVID cases. And it's just a huge challenge. And there's a number of things that are being done within that institutional environment to keep things safe. One is increasing use of Zoom and things like that. Your lawyer doesn't have to come, your family doesn't have to come physically to be across the glass from you. You can do that with an iPad that's been that's been properly cleaned. We can try to reduce the number of people that are sent to jail, and so arrests are down in many, many places. One thing, because people are inside, certain kinds of crimes have just gone way down because nobody's out in the, you're not getting a DUI arrest because you're not driving anywhere, and there's a ton of stuff that's so arrests are down, but also there's a real effort to try to avoid moving people into the jail environment. In the prison environment, there's a real effort to figure out how can we who are the people that we can most safely let out. So you have someone who's an older person whose risk of violence is much less, whose sentence is going to run out later this year. Why don't we let them out now?
Mm-hmm.
Get them out of there. Are there ways we can put people, there are people who are being held basically to make sure that they show up for trial. A lot of those people can be home on electronic monitoring, and they're going to be a lot safer, and they'll keep everybody else a lot safer if we just keep them out of the jail environment. So there's a huge amount of effort that's being made to say, how can we reduce the census in our jails and prisons to keep down the infection risk, and also, of course, how to follow all the appropriate guidelines for sterilizing everything. You don't have everybody in the dining hall jammed on top of each other having lunch. There's a ton of ways that they're trying to sort of lock down procedures to minimize that risk, but there's only so much you can do. It's a big challenge.
Going from one difficult subject to another, you wrote another Washington Post piece tackling the truly painful question of how medical personnel might make decisions about which patients get access to particular kinds of treatment in the middle of this crisis.
Yeah.
What kind of tools does the medical profession typically use to think through these kinds of decisions? And do these tools apply in the current situation, or do we suddenly have to be thinking differently?
Wow, we've been talking about all the easy stuff up to now.
Right.
So if we actually have to triage ventilators and critical life-saving or life-extending interventions, how would we do it? Yeah. Now, the tools of medical decision-making, I teach sort of cost-effectiveness analysis for public health and healthcare. There's a course that I've taught every year at Chicago, where we apply the standard economic tools to try to understand, is it cost effective to vaccinate people? How many, when should we build guardrails along the highway for the highway that's not driven around a whole lot, this kind of thing. And the standard tools that we use try to say, if you can get a year of high quality human life, our society is basically willing to spend about $150,000 to do that. And so that's called a quality adjusted life year. And when we debate, say, the cost of a new cancer therapy and how much the government should reimburse a pharmaceutical, company that developed a new lung cancer treatment, we often, in various ways in the policy community, try to apply this $150,000 per quality adjusted life year standard. And at some common sense level, it makes sense that if I can get another year of really healthy life for a 22-year-old, that's worth a heck of a lot. If I get you another year of life when you're in a coma and then you're going to die, that's not worth a lot. And of course, every interesting case is in between those two. And one of the challenges that we have is, how do we do that if we're actually out triaging life-saving interventions? How do we do that in a way that does not disparage the lives of people who might live with a disability or who are older? It's one thing if we're debating the cancer treatment and none of us has developed that cancer yet, and we're sort of trying to figure out, taking a calculated risk on behalf of ourselves. I got the cancer treatment and I've got this other thing that can save lives. Which one do I want to invest in? And I don't know really whether I'm the person who's going to benefit from one or the other. That's of course very different from, I have Harold's mom and I have Harold's daughter, and they're both, there's only one ventilator. They're both COVID's patients. How do we prioritize that? There was an economic study that was done that said if we do really dramatic measures to try to slow the COVID pandemic down, it would probably cost us like $2 trillion, and it might save 600,000 lives. And the question, is that worth it or not? It becomes a real challenge. And I've had some ethics consults with some hospitals where the people have just called me and said, how do you think we should solve these problems? And what I've tended to say is, you kind of have to decide based on the why. It's a little bit, and that's often much more justified than deciding based on the Q. If we're talking about quality of life versus length of life. If I'm going to live another 2 months, and my daughter, if we save my daughter, she could live another 50 years. That to me is ethically, I have to weigh that. It's not like we think that I'm any less valuable as a person than my daughter. It's just that we don't know how to help me get beyond 2 months, and she could get 50 years. And plus, I've had a chance to be a 57-year-old man, and she has not had a chance to be a 57-year-old woman yet. So that's fair. If you said, this person has an intellectual disability, he's going to live 50 years. This other person doesn't have an intellectual disability. I'm much less comfortable with making decisions on that basis. It is because that's really saying that person's life is not as worthwhile. And even though he enjoys his life, thinks it's very valuable, I don't. And I think that's territory that I find very, very problematic. And so I would be, I've been of a philosophy that thinking about how long people can live, whether they've had a chance to live a long lifespan, and the third thing, by the way, is how long they will need the ventilator. Because if you have someone who might need that ventilator for 5 times as long as someone else, that for me might make them a lower priority for that, just because there's so many other people that could be helped with that one resource. But that's not saying that person's life, it's not making a disparaging judgment about that person's life. It's just saying we're in an emergency. I'm not sure if I'm addressing the exact question that you were asking, but it's one that I've been thinking about a lot. And I'm hoping we can avoid that situation. It is the standard methods that we use in public health when we're thinking about rare risks that are sort of probabilistic. I do think they don't work super well when we think about pervasive risks that we're facing right now with identified people. And so the EPA has an official standard that they will save one statistical life. They will spend $9.6 million to save one statistical life. And if you applied that standard and you said we're going to save 600,000 people from COVID, you'd be willing to spend almost $6 trillion on that with that standard. And some people are saying, wow, that's a lot of money. Is that really realistic? And I don't know. But it's certainly a gut check for all of us who work in this field.
We have another conversation with another expert that's going to get into the details of the federal aid package. But can you just give us sort of your overall impression, right direction, wrong direction, things we need to be thinking about for the long run?
Well, I think that the current dilemma highlights how important it is to have a social insurance structure that protects all of us. We can all protect each other against calamities that would just crush any one of us if we had to face it on our own. And the economy has just ground to a standstill. We've deliberately ground it to a standstill to protect each other from this epidemic. There's going to be millions of Americans who can't pay their mortgages, who need help putting food on the table, who have medical bills that they can't pay. And we have to, as a society, bear that risk. And the rescue package is a way that we do that. Some of the things that are in that package are essential because our safety net is so inadequate, without that package. And many of the social democracies in Western Europe have had an easier time shutting down physically distancing the entire economy because people know that they're still going to get paid, because small businesses know that they will be protected. And, there's a huge amount of risk spreading. And, it is, and I do think after the COVID-19, after we get over this crisis, I think some of the measures that we put in place for things like emergency sick leave and paid family leave, things like that, some of that will, my guess is that some of that will stick around, and people will say, you know what, we need that. And okay, there won't be a COVID, but there'll be a woman who's got kids and she's got some sort of a really serious personal medical problem. She needs to have sick leave for that. And we should there will be aspects of this aid package that will become part of the American welfare state in some way. Now, one of the things that we need to do is do that in a regularized way. I think we have to do this so quickly that we're not necessarily setting up institutions to do it in the most careful way with the most oversight and transparency. And particularly when you're talking about subsidizing corporations, I'm sure that there's going to be some very serious issues about oversight and potential political misuse of these funds and everything like that. But there's no question that when the overall demand for goods and services in the society collapses and individual needs are left unmet, that's the federal government's responsibility. And in some ways, it's a kind of time-lapse photograph of what we had to do during the Great Depression, when all of the private safety nets were just overloaded, with the in the Great Depression, and the need that we needed to develop Social Security and other structures that would undergird that. And we need to take seriously that we live in a mixed economy that requires a lot of government support for these moments of emergency.
I can't let you go without bringing up the fact that you published a book in 2016 with the journalist Helene Olin called The Index Card: Why Personal Finance Doesn't Have to Be Complicated, which argued that everything you need to know about how to save retirement can be written in plain language and fit onto an index card. The current crisis has led to a great deal of anxiety about retirement and about financial stability in general. What are you thinking about right now about these issues?
Well, there's two tracks to that. One is what individuals themselves should do as we try to manage our own personal finances, and certainly, if you have a 401k or a similar arrangement, you don't want to mess with it right now. You just want to keep doing what you're doing, and you never want to try to time the market or panic when something bad happens. So, you should be buying basically boring index funds and just keep doing what you're doing if you're just a normal person saving for your retirement. I do think that if we think about this from a policy realm, from a policy lens, it really indicates how we need to do more to protect people, achieve a secure retirement, to achieve secure savings. There are people right now who are sending their kids off to college next year whose college accounts have just taken a 25% decline. And there's many, many more people who just don't have those kinds of savings at all. And I do think that the current system that we have is beautifully set up for upper middle class people who have good jobs, who benefit from the tax subsidies that are given to these, to not only our 401ks, but also our 529 accounts and a whole alphabet soup of things. And that one lesson of this crisis is that there's just, most Americans really cannot rely on that. And if you have retirement savings, but you've also lost all your work hours and your mortgage payment is going to come due, you're going to have to take money out. Potentially, you're going to have to borrow from your retirement in order to pay your bills. And what you're effectively having to do is to sell your stocks at the moment when it's like hitting the bottom. And that's going to have a lifelong consequence for a lot of people. And we have to help people in those situations. And I think that I'm obsessed with personal finance and finding strategies to manage your money well. And I hope that I've helped people with that. But I also see very much the limits of that. Rocket science is really great when you have rockets. And so, if you're a University of Chicago professor, I can give you a lot of help in how you should manage your retirement savings. If you're a janitor at a big box store that has just taken away all your work hours, me coaching you is not your biggest problem. I could probably give you some useful advice, but that's not really what you need. What you need is a Social Security system that's going to protect you, an unemployment system that's going to protect you, a set of structures that protects you from having the worst consequences of this catastrophe. So I see the value of sort of personal financial management, but I also see why that could easily be incredibly overrated. And I'm sure Helene would say something very similar. But do keep contributing to your retirement at the same level. Don't bail now. So,
as we conclude, these conversations about the COVID crisis are really difficult to have, and I'm sure they're really difficult to listen to. As we wrap up, is there any aspect of the situation that gives you a sense of optimism? Do you see any good things coming out of this otherwise fairly horrific situation?
I do. I think that sense of solidarity and the small acts of kindness that people are doing all over the country, and to see the bravery of people and the generosity of people is a beautiful thing. And that's the moment we're in. We have to help each other, and that's what people are doing. I've had a ton of people. I've just seen 1 million people in my life, and we're not in my life, but people that I've learned about, who are bringing food to seniors, who are calling people up, who have menial jobs, but jobs that keep everybody else safe, and who are showing up and doing, and in a way that maybe we didn't appreciate. Who's the most important person at the University of Chicago? Maybe it's the cleaning people who have prevented us from getting infected. It's the security people who keep us safe so that we can feel like we can stay home and feel safe. And I think there's a recognition of that, that's a very real thing. And where we're physically distancing ourselves, but in some ways we're closer to each other than we otherwise would have been. And we
Mhm.
want to, and that's, I think we can feel a pride in that. And,
Mhm.
we haven't, I think we want to be one society where people take care of each other and across a lot of differences. I've seen a million examples of that. So that's what makes me optimistic.
Well, I think that is a good note to end on. I'm so grateful that you took time out for this. I know everyone is incredibly busy trying to manage life in our new normal, and given what you study, you are particularly busy. So I really appreciate the time, and I wish you well in this crisis,
Likewise.
personally and with your work. Thank you so much, Harold, for joining us.
Thank you for having me, and I wish you well as well. And good luck with
Thank
all
you.
these conversations. I think that's a fantastic resource.
Thank you very much. Take care of yourself. Bye-bye.